Thank you. Okay. Okay, so we're going to start with chapter 11. Okay. This is week 2. We will be doing chapter 11 today and also chapter 12. Okay. Chapter 10, just to let you know, basically went over, the only thing that I kind of focus on with that chapter, because it goes over basic immune system stuff that you probably learned from anatomy and physiology. But the only thing I wanted you guys to look at with that was just the 4 different type of hypersensitivity. So what I will tell you to do, I'm not going to pretty much test you on it, but just kind of read it at home, okay, just to familiarize yourself with the 4 different types of hypersensitivity, because you will see this term come up again and again, okay, throughout the term. Now, with chapter 11, we are going to go over malignant disorders of white blood cells. So basically, we're going to go over in detail all the different types of leukemias. We will go over pretty much their pathogenesis, well, their kind of pathogenesis, or what I call hallmarks, okay, because there are some hallmarks with these diseases that sort of stand out. So whether they have a particular chromosome or a particular pattern of the way it spreads or what have you. We will also go over treatment and signs and symptoms, okay. Now, just to let you know, we also have histology slides, okay, that are with this, I'm sorry. Okay, so we will be looking at some histology slides of each and every leukemia, which I will tell you, yes, you will be tested on for next week. Okay, so next week's pictures will be all those pictures of the histology slides that you see on e-college that have the blood, okay, blood cells. What else? And we're going to go over also lymphomas. Okay, so this chapter is pretty long, just to let you know, so it'll probably take me 2 hours to get through, so we'll do the first hour, take a break, and take it from there. Okay, now, we will go over leukemias, lymphomas, and also what is known as plasma cell myeloma. So sometimes individuals can have a cancer to a plasma cell, okay? And they do call it separately than a leukemia, because a leukemia is to white blood cell. Leukemias, as you know, can circulate, okay, and they can also definitely spread and go, obviously, throughout the circulatory system, and definitely involve blood and also bone marrow. Lymphomas can sometimes be localized to just lymph nodes itself, or maybe spread throughout the lymph tissue, or let's say lymphatic system. And plasma cell myeloma is just what it says. This is OMA, well, I don't want to say OMA as in benign, but this is a malignancy to a plasma cell. Okay. They give you the categories here, and one thing I just want to point out here, and I'm going to show you a chart in a second, is that we do have something called the myeloid lineage and then something called the lymphoid lineage, okay? Now, the reason why I want you to memorize what lineage these cells come from is because I'm quite sure you guys have heard of CML, CLL, ALL, okay? So when we talk about, say, for example, ALL, this is an acute lymphocytic leukemia. So just to give you an example, so if we're talking about something acute, that's telling us that yes, it's a rapid or fast course. Lymphocytic is going to tell us that it comes from a lymphoid lineage and then the leukemia. Okay, so if you know something that's an ALL, say for example, we know that it's going to target these cells here. Okay, B cells, T cells, and natural killer cells. As opposed to something that comes from a myeloid lineage is going to attack red blood cells, platelets, monocytes, and granulocytes. Okay, so even just by looking at the name of the leukemia, you should be able to know what types of cells it's actually targeting. So this is showing you here, and we all know that stem cells come from, all blood cells do are derived from one stem cell, okay, and they give rise to all of these different types of cells. So here's our lymphoid lineage, as I told you. So just to show you our lymphoid lineage, we have our natural killer cells, B cells, and T cells. They can interchangeably be called either leukemias or lymphomas, depending on the location. So if it's in the bloodstream, we know that it's a leukemia. If it's in lymphatic tissue, it is considered a lymphoma, okay? But we know that these cells are located in those regions, okay? So they can be either leukemias or lymphomas. Make sure you know that. Now, when we go over to myeloid lineage, these are only called leukemias, okay? So they are only localized to leukemias or to the blood. So we have our neutrophils, monocytes, red blood cells, and our megakaryocytes. Okay. Now, this here, we don't have to worry about this so much. This is just going over the different names, and we're going to go over each and every leukemia in a second, so you don't have to worry. Now, how do people get leukemias? Just like any other cancer, we don't have a known cause, but there are some things that do kind of put us maybe like a risk factor, so to speak, okay, of these different types of leukemias. So one thing is that they call is viruses. Viruses, some viruses can give rise to different types of lymphomas, such as, for example, the Epstein-Barr virus. It has been kind of tested and known that individuals that do have a history of the Epstein-Barr virus can give rise to having a different types of lymphomas. Okay, so just keep that in mind, and we're going to go over that in a little bit. Okay, so not to say that everybody with the Epstein-Barr virus is going to get a lymphoma, but it's just a possibility that these individuals may be at risk for it. People with radiation exposure, so the more radiation you're exposed to, what radiation does, it actually kills rapidly dividing cells, okay, which is definitely going to be our blood, okay, which is one of our rapidly dividing cells, which is sort of like a catch-22 because, as you know, some patients have to have a radiation therapy, okay, yes, but radiation also kills, as you know, kills everything. In the same situation that happens with chemical exposure as well. So some chemicals can kill these rapidly dividing blood cells. Okay, but it's not many risk factors that go along with this. Now, most common clinical manifestations. Now, let me tell you this. Most of the manifestations that occur with these types of leukemias and lymphomas, some of them they share the same common signs and symptoms. So what I would advise you to do when you are writing your notes or studying for next week's quiz, please kind of just write out all the clinical signs and symptoms for each disease, and then just kind of highlight, okay, well, these 3 have fever, these 3 have weight loss, okay, these 3 have bone pain or whatever. So just try to kind of put it in a color-coded or something, some way where you can memorize it, because what will happen is I will have questions on the test, okay, next week as far as, okay, well, which diseases have the most common signs and symptoms, okay, whatever. So just make sure you're able to put them in some sort of category like that. Now, leukopenia, we already know that this is definitely decrease in white blood cells, so they will have pretty much lymphadenopathy, joint swelling, pain, weight loss, anorexia, which goes along with this. Now, hepatomegaly and splenomegaly. Why do you think that they're going to have an enlarged liver and an enlarged spleen if they're not having a lot of white blood cells?
The liver's trying to detoxify all the poisons.
Very good. The liver's trying to detoxify pretty much all of the abnormal cells, or let's say the cancerous cells, so to speak, that's in the body. But then also, what is the spleen doing too? The spleen is trying to catch up for what the body is not receiving. Okay, so the body does not have the adequate amount of white blood cells, so the spleen is actually trying to boost the immune system as much as it can. Okay, so just keep in mind that this is actually what we call more of a compensatory mechanism, I think that's a correct term that we can use here. So because the body is lacking something, what's going to happen is these other organs now are overworked, okay, because of it. So therefore, it'll put it in a state of a megaly. Okay, is everybody with me with that? Okay. Now, anemia. Anemia, we already know, decrease in red blood cells, fatigue, paleness, shortness of breath, okay, all of that because the person does not have all the red blood cell, obviously oxygen carrying capacity, that should be going through the bloodstream. And thrombocytopenia, as you said, someone said earlier, yes, the bleeding definitely under the skin, the petechia, the purpura. And we'll get more into those bleeding types of situations that happen on the skin because we will do a whole chapter, I think next week, on bleeding disorders. Okay, so we'll go over all of that later on. Now, neutropenia. Now, they put here neutropenia and they just kind of singled this out, okay, out of all the white blood cells. Why? What is so important about neutrophils? What are some things that you know from anatomy and physiology, more so from anatomy, that you learned about neutrophils?
They're part of the immune system.
They're part of the immune system, and then what are some of their functions?
They phagocyze like debris.
Very good. Neutrophils are highly phagocytic. Okay, please don't forget that. And remember, when we talk about the fact that they're highly phagocytic, they pretty much just kind of eat and sweep away anything that's pretty much in the area. So if a person has a low neutrophil count, this is not a good situation for them trying to fight infections. And the other thing too that you know, neutrophils are the highest count of white blood cells out of all circulating white blood cells. So remember that we have more neutrophils out of any white blood cells. So they are extremely important. The other function that you may not remember is that neutrophils are the first ones on the site for any type of infection, no matter if you're having a bacterial infection, viral infection, even cancer. Neutrophils are there. They're the first ones on the scene. Now, the other thing here is that they're talking about evaluation of a peripheral blood smear. Okay, this is extremely important when you're diagnosing different types of leukemias. Okay, because this is where the histologists or the pathologists, people that, I have a friend of mine, she's a histo tech. She looks at slides all day and night. I don't know how people do that, looking at microscopes all day and night, but this is what they do. Okay, and they look at all of these different slides and they look for different types of abnormalities with the cells, and to see, okay, if these people have cancer, the degree of dysplasia, and so forth. So when we're talking about a peripheral blood smear, do you guys know what that is? You looked at one, but okay. Peripheral blood smear, just to let you know, and actually your physiology book, which we can't perform this actual lab on campus, but basically in your book it had a lab, okay, where you kind of prick your own finger, take the blood, put it on a microscope slide, you take another slide at a 45-degree angle and smear it. Let it air dry, put a cover slip over it, and then you're actually going to look at these cells under a microscope. What do you think is the purpose of doing that whole peripheral smear? It's a smear. Very good. Morphology. Morphology is the first thing that you're looking at. So please keep in mind that they have to do a peripheral smear in order to, this is one of the things they have to do, in order to diagnose these types of leukemias. So they have to do a peripheral smear to look at the morphology of the cell. This is the only way you're going to be able to tell if the cell is in a state of dysplasia or anaplasia. Now, once they do that and look at the peripheral smear, the other thing that will happen is that the definitive diagnosis is obviously doing a biopsy, okay, of that tissue area, or the bone marrow itself, or the lymph node, okay, and then they will also look at the cells in that tissue. Now, principles of treatment. Let me just explain. Chemotherapy, we know, is there to definitely try to remove the malignant cells or to try to kill it, okay, as much as they can. When people have what is called stem cell transplant, this is definitely to restore the bone marrow function, or to kind of just clean out and give us a new, nice new healthy bone marrow, okay, as you know. Radiation and tissue-specific therapy will sometimes be used in leukemias, but not so much. They definitely use more chemotherapy and bone marrow transplant, okay, just to let you know. And we're going to go over that in more detail in a second. Now, chemotherapy is definitely to give these people what is called long-term remission. Now, we already went over the term remission in week 1. Remission is making sure that these individuals stay not having an increase of malignant white blood cells, okay? And so the whole thing is that with the complete remission, you want to make sure that these individuals not only have free of cancer, but making sure they have normal blood count in all blood cells, platelets, red blood cells, white blood cells, everything. So everything should be healthy. That's what we want for complete remission. So please keep in mind that that is the goal of any type of cancer treatment, especially with leukemias. They want to make sure that all of the blood tissue is healthy. Now, what will happen is remission will eliminate all of the neoplastic cells and achieve complete remission. But what will happen is after post-remission, they will still give these patients, and I think, yes, here we go. Here. They will still give these patients chemotherapy 2 to 3 years after they are still into remission. So as soon as they hit initial remission, even though, okay, everything looks nice, blood count is up to par, no detection of malignancy cells, okay, everything looks good, but keep in mind that these patients still have to go through 2 to 3 years of chemotherapy just to make sure there are no undetected cells. Why? Because we know blood cells are rapidly dividing. So who's to say if that person goes into a complete remission today, in the next couple of months, because we have these cells that are rapidly dividing, that there may be a malignant cell going through mitosis that could be lingering, okay? So they want to make sure that this is taken care of by continuing that chemotherapy. Okay, now, some of this stuff we talked about before. So what will happen is with these individuals, as you know, some of the signs and symptoms that kind of go along with this whole process of cancer, anorexia, weight loss, vomiting, stomatitis, infection. With infection, especially with patients that do go through leukemias and lymphomas, sometimes they do try to prevent certain infections and try to pre-treat certain situations. So sometimes, as you guys know, in hospital settings, and those of you who already work in the field, you know that sometimes you will give patients sort of antibiotics, sort of as a prophylactic, to make sure that if they are susceptible, may be susceptible for getting infections, and especially after certain surgeries and certain procedures, even if they don't have a known bacteria, okay, that they're tested for, but just to kind of make sure they don't go that route. Now, the next thing I'm going to go over with you is understanding bone marrow transplant and how it's used. Okay. Now, they use bone marrow transplant, just to let you know, a lot with treatments for leukemias. But please make sure you know this and jot this down. This is protocol from my understanding, is that these patients always have to have a round of chemotherapy first before they have a stem cell transplant. And that makes sense. Because why would you want to introduce a brand new, nice, healthy bone marrow and they have a bunch of malignant cells just roaming around, okay? So you want to make sure that they do keep around the chemotherapy to try to kill as much malignant cells as they can first, and then introduce the nice, healthy bone marrow, okay? So that's basically what's all that's saying. Now, the other thing too is that there are 2 different types of stem cell transplant, which I'm going to go over in the next slide here. So we have what is called the autologous transplantation, where stem cells come from the patient's own blood and can be reinfused. Okay, so I bet you're wondering how would they do that and why would they do that? But this is what they do. They will actually take the patient's blood, and just like almost similar to when a patient has dialysis, they will take the blood and put it through this apheresis machine. And through this process of apheresis, it will actually pull out the nice healthy blood cells and the nice healthy blood tissue and reintroduce it back into the person's body. Now, sometimes, depending on the type of cancer and how aggressive the cancer is, this type of treatment can't be used for everyone. Okay, so everyone can't get the autologous type. Then we have the allogenic type, which a person is getting a stem cells from a donor. Okay, so someone that is a close enough match to give them that situation. So they're showing you a nice picture here, okay, of someone with the allogenic portion. Okay, so they have a donor, and this is the autologous one, where this person now has their own stem cells reinfused. Now, turn it over. Okay, now, no, this chapter is long. Now, when these patients do go through an anemia, okay, so unfortunately, when patients do have a leukemia, this is just one of the things that kind of go along with it, that they will have an anemia. So we can tell that by looking at the peripheral smear, as you said, looking at the morphology, we can see how many red blood cells they have, okay, if they have any kind of abnormal shape to them and what have you. If they have any type of abnormal shape, obviously they are not functional. They are not considered to be functional red blood cells. And I'm going to show you some pictures in a second. Now, how do you treat an anemia with a patient that has cancer? The way you do this is by giving them erythropoietin growth factors. And what is erythropoietin going to do? Thank you. It will stimulate red blood cell production. Okay, if you remember that from maybe anatomy. Okay. And where does erythropoietin come from normally? Where is it secreted normally from in our bodies? Very good, the kidneys. Okay, so the kidneys will secrete those erythropoietin red blood cell growth factors. Okay. They can also give them red blood cell transfusion if needed. Okay, and anything else to prevent the bleeding. Now, for pain most of the time is in the bones and the joints, okay, with these individuals. They can have sometimes bleeding in the joints, which is called hemarthrosis. And I do have some pictures that I didn't get a chance to pull up. But in any event, I do have pictures posted on Ecology of a person that has hemarthrosis. So basically the joint is just swollen and you can just tell that it's filled with fluid and blood. Also, sometimes the procedures can be painful, and obviously also if these individuals have skin lesions, okay, that can also add to their pain. Now, when these patients, again, and I talked about this before, so not to repeat myself, when they go through radiation and chemotherapy, it can kill the epithelial cells, okay, so this is where they get skin loss, the skin sort of just kind of sludges off, mucous membrane, the hair loss, which we all know is the most common thing that happens with cancer patients, and especially patients going through cancer treatment. They lose the hair, okay? So that's that. Okay, now, myeloid neoplasias. We don't have to worry about this slide. You can cross that one out. Give me a second.
I already put an X over it, so.
No, it's okay. It was something I wanted to say about this. Oh, I know what I wanted to say. I wish I had a board in here because I really need to write, but I can use this now.
Why don't you use it back to one of our projects, no?
Yeah, but I'm recording and you may not be able to see it. It's okay. I'll just use this as an example. Okay, let me just use this picture as an example. Not that I need you to know this information on the picture, but you get it, okay? Now, when we have a stem cell, we know stem cells give rise to all different types of blood cells, okay? So we got that. Now, what you should know is the difference between an acute leukemia and a chronic leukemia, okay? So sometimes people wonder, okay, well, how is a leukemia acute and chronic? When we have these cells, remember when we have a stem cell, it goes through a maturation process, okay, in order for it to get to the mature cell, the mature red blood cell, the mature white blood cell, whatever it may be. So what happens here is as it goes through the maturation process, okay, so say for example this one is going through the maturation process, and then all of a sudden right here, before it matures, right at the immature stage, it becomes cancerous. So when you have a cell that is cancerous at an immature stage, this is considered to be an acute leukemia. So please understand that acute leukemias attack the cell at its immature stage. Whereas a chronic leukemia, as you can imagine, because you know chronic diseases take a longer time to progress, chronic diseases attack cells at its mature stage. Okay, so that was the main thing I just want you to get.
So when a cell is cancerous at its point of immaturity,
It's acute.
acute.
So we're considered this an acute type of leukemia when it's attacked at its immature stage. And when we have a cancer that is considered chronic, this is when it attacks it at its mature stage. Okay, so the final cell at its mature stage. Okay. Now, just to add to that, and you don't have to jot this down if you don't want to, but we'll see it in a little bit. When we have acute leukemias, because they do attack at their immature stages, as you know, say for example here, here, and here, we have 3 different types of immature stages, which means that sometimes acute leukemias can have different names or different subtypes. okay, because of the fact of where it's caught at its different stage. So I just wanted to say that as well, and that's it. Okay, so that little bit of information I gave you will help you as we go through each and every leukemia. Okay, so this information I'm not worried about because it's just kind of giving an introduction, and we can just get started right with CML. Okay, is everybody okay, or do you need a break? Because I know you guys had chapter 7.
So we just crossed out myeloid neoplasm?
Yeah, if you want to read that, but this is just an introduction. It's just introducing the myeloid leukemias that we're going to talk about. So I'm going to go over each and every one. Okay. So we're okay. It's just 4 slides. I think we had to cross out. It's never. It's okay. You're not missing anything. Okay, CML. So just by looking at the name CML, chronic myeloid leukemia, and let me tell you this, for next week's exam, please make sure you know the long name as long as the abbreviation, because I may have some of the questions abbreviated. So make sure you know the abbreviation as well. So I don't want you to get confused. Okay. CML, chronic myeloid leukemia. So what is this telling you in the name? Chronic meaning that what? It attacked a mature cell, and because it's a myeloid lineage, what type of cell do you fall under this category? Okay. I'm sorry, yes, I know you didn't memorize the slide that quick.
Leukemia?
No, it's a leukemia, but what type of myeloid, what type of cell is it attacking? Neutrophils, monocytes, megakaryocytes, okay, so everything that falls under that myeloid lineage, okay? Now, because we know neutrophils are high in abundance, okay, most of the time these myeloid leukemias are going to attack neutrophils, just to give you a heads up. Now, not to say that they won't attack other cells, but because neutrophils are in abundance, that's usually the first ones that kind of get hit, okay? Now, excuse me. This slide goes over the sort of the background, almost the etiology. I wouldn't call this the pathogenesis. But the etiology, 15%, okay, average age onset, 40 to 50 years. Occurs occasionally in childhood and adolescence. But just to let you know, CML is usually more of an adult leukemia. So I don't want you to think it's a childhood leukemia. It's more of an adult leukemia, okay, just to let you know. Now, this information, please also study this background information, because what will happen is I will have some case study type questions, and I will plug in like the age ranges and some of the background information that we have here in the introduction. Now, with CML, what they notice, and this is characterized by malignant granular sites, okay, and so one of the most abundant granular sites that we have are neutrophils, okay, and what they notice is that it carries something called the Philadelphia chromosome, okay, so you're probably wondering what is that. Philadelphia chromosome is actually a mutated gene that they actually discovered, okay, a scientist from Philadelphia, that's the reason why it's called Philadelphia. He actually discovered this with these individuals that have CML. So he discovered this particular gene that they have. And basically what happens is that they have a translocation of chromosomes 9 and 2, okay? And then it goes into how it juxtaposes and so forth. I'm not going to ask you all of this information, but I just want you to know that there is a translocation of 9 and 22.
So you do want to know that?
Yeah, I want you to know 9 and 22 and stop there. Now, let me just show you what we're talking about. So here's chromosome 9, here's 22, and what happens here is that there's a translocation of 9 and 22. So this portion here just kind of pulls up down there. This here just kind of goes over there, and it makes this new chromosome called the Philadelphia chromosome. So it transfers the genetic information from 9 and 22 and makes this new gene, okay? So he noticed that these individuals that have this new gene now are the carriers, or I guess you want to say the carriers, or the people that do have this particular type of leukemia, okay? which is the CML. Okay, so please make sure you know Philadelphia chromosome CML. So this is what I consider, when I was telling you hallmarks, okay, this is what I consider a hallmark for this particular disease. Because only patients with CML have this sort of gene mutation. Okay, they have this only type of Philadelphia chromosome G, BCR, ABL. Okay, fusion. Okay, now, can someone hit the lights for me because we got to go through this slide. Thank you. Now, what are you looking at? Neutrophils. Okay, so we know that these are neutrophils by looking. Well, I told you they were neutrophils earlier, but okay. Other than me telling you that they were neutrophils, what makes these neutrophils?
Well, they're engulfed, right? I don't know.
They're sort of bilobe. So yes, neutrophils. Somebody said bilobe. Neutrophils are bilobe. And what else about neutrophils? Normally about neutrophils. Okay, the dots are what we call granulars. Okay, so they do have granulars in the cytoplasm. So remember, neutrophils are considered our granular sites. Okay. Now, what is the problem with these neutrophils here? Okay, so we have one here, one here. What seems to be the issue?
They're correct, yeah.
Misshapen.
I'm sorry, say that again.
Like misshapen?
They are a little misshaped, but then what else about their that kind of goes along with shape? Size, very good. They are very large, okay? Neutrophils should never really be that large. Okay, when you look at what is the largest white blood cell in the body or in blood? What's usually the largest if you would look at under a microscope? Very good, somebody said monocytes. Monocytes are usually the largest, okay? Keep in mind that if we're looking at any other type of white blood cell, it should be pretty much the same size as a red blood cell, okay? Now, what is another problem here with these neutrophils that's kind of hanging out here? They are too close together. Very good. Let me tell you something about white blood cells. The only time white blood cells cluster up like that is if a person is going through an infection or some sort of disease process. When you have white blood cells, and if you remember from normal anatomy, if you took anatomy here with histology and how you had to go through all those slides with Dr. Youssef, and what happened when you look through the blood slide, remember how long it took you to find a neutrophil and a lymphocyte, and it took you forever to try to find maybe one or two. Now we're looking at this slide here, and they're all clustered together. They're right there in your face. So this tells us that this is an abnormality. Okay. What else is going on? Let's just say, for example, this neutrophil right here. The white spots means that the cytoplasm is actually now being degraded, which means that this white blood cell is pretty much on its way out. Okay, so this particular one is dying. What is the issue with the red blood cells in the back?
Like clumped together.
They're clumped together, but then there's also something else. They are also degrading. They have these big old white spots in the middle, which should not be there. Red blood cells, if you remember from anatomy, normal red blood cells just kind of look nice and, where's a normal one here? Okay, just kind of nice and circular, okay, nice and sort of reddish, pinkish color, okay, all the way through, okay, because of the hemoglobin factor. But keep in mind when we look at these,